I gave a talk on initiation of treatment for high-risk smoldering myeloma, and it was a debate, so I was arguing for yes to do that. The person who was arguing for no was my colleague and friend, Dr. Vincent Rajkumar from the Mayo Clinic. I gave an overview of the options. I said if you do nothing, we know the disease is going to progress into symptomatic multiple myeloma. And then I looked at some selected studies and I presented and reviewed the data by the Spanish group that was published in the New England Journal in 2014 when they compared Rev-Dex versus nothing. And they showed that there is a progression-free survival and there is an overall survival also in their study. So I said, how can you not treat patients when you have these findings? And of course you have to look carefully at the data. There are a lot of caveats with that study. It's small and there are a lot of other things that should be addressed. And then I pushed further and said, what about using the better or the best therapies we have even for multiple myeloma in the setting of high-risk smoldering? And I showed some of our own work where we have used the combination of this Revlimid, dexamethasone plus carfilzomib. So we had a triple drug. So I had a 2-drug and a 3-drug combination, which is the same type of approach we have in newly diagnosed patients, of course. And then I showed, and these are data that I will present here at ASH as an update, and this is the final results from the study I developed at the NCI when I used to work there. So I showed that all patients reach a complete response. And I also showed that if you use these newer technologies to detect minimal residual disease, that the vast majority of patients are MRD negative. In fact, 11 out of 12 were negative with the flow cytometry approach, and 10 out of 12 in this first series were negative with next generation sequencing based MRD. So I made a case that if you treat early with effective therapies, you can obtain very good responses. And I said, if this is going to be the way it is, this could become the standard. But then I also made a little halt there and said, that's an important question. We're exposing these patients to drugs that could be toxic. They are toxic to a certain degree. All drugs we use are a little bit toxic. So for that reason, I wouldn't do it outside a trial. So although I was arguing for, I said, at this moment, I argue for, but always on a trial. And I would not treat patients with high-risk smoldering myeloma outside a clinical trial. I do envision this is going to change, but for right now, I think that's the right thing to do so we can capture data and make sure that these good responses are maintained over time and we're not inducing a lot of other problems, toxicities, or pushing the disease so it becomes non-responsive to treatment later. So these are important issues. And I do think it's a very complicated ethical situation because now we have these new data. So for people who don't have access to trials, what do? It's easier for people like me who develop trials to argue for it, and I can completely see that. But if I'm asked, I do still think that the trials are needed, but I also realize the other side of the coin, so to speak.